Hello, Medscape. This is Dr. Mark Lewis, Director of GI Oncology at Intermountain Healthcare in Salt Lake City, Utah, and I'm coming to you to summarize some of my takeaway points from the 2022 ASCO GI Cancers Symposium. Many oncologists will tell you the litmus test of a successful conference is how much it affects your practice, and I do think there were data presented at this meeting that have certainly affected practice immediately and also given us a sneak preview as to how our treatments might change in the future. There were three particularly catchy trial acronyms, and I assure you that my interest in them is not just clever wordplay. I think this was actually meaningful research. So I'll start with Crystal 1, and that's Crystal with a K, as a hint that we're looking at, can we make KRAS mutations druggable? These have famously or infamously been considered non-actionable mutations for many, many years, especially in the field of GI oncology. And then recent advances in other areas like thoracic oncology have really raised our interest in seeing if particular KRAS mutations can be exploited in otherwise refractory GI cancers. So Crystal 1 looked at pancreatic ductal adenocarcinoma and other non-colorectal GI cancers that had previously been treated and specifically harbored the KRAS G12C mutation. And we'll come back to why that's so important in just a second. Again, we're going to be looking at a subset of a subset here. So of the 42 patients in this phase 2 study, 12 of them had pancreatic ductal adenocarcinoma, and 10 of those were evaluable. But I think what's so remarkable is in a fairly heavily pretreated population with median lines of therapy being 2, and that ranging from 1 to 5, the disease control rate was 100%. And DCR, of course, is the sum of response rate and stable disease, and that was 50-50 exactly. So the median progression-free survival here was between 6 and 7 months. And the reason I bring this up is, for years it's been easy, even for GI oncologists, to adopt an attitude of therapeutic nihilism when it comes to pancreatic ductal adenocarcinoma. And so often, when we do sequencing on these tumors, 90% of the time, in fact, we find a KRAS mutation. But what you're looking for here is the diamond in the rough. Among those KRAS mutations, what small but actual minority now have G12C? And so I think it'll be really important to look out for those mutations and to consider adagrasib, which is a covalent inhibitor of G12C. Moving along, I was also quite taken by TOPAZ. The TOPAZ study is really the first study to, I think, substantively improve on the first-line standard of care of gemcitabine and cisplatin in advanced biliary tract cancer. Of course, ABCO2 established that doublet as the backbone over a decade ago, in fact, during my own fellowship. And since then, we've been trying to see, can the addition of an agent meaningfully change the benefits that we derive from GemCis? And I think the answer here is a cautious yes. This trial did show an improvement in median overall survival. It was 12.8 months in the Durva arm versus 11.5 months in the GemCis arm. And also the hazard ratio was 0.8, so a 20% reduction in risk of death, again with the addition of durvalumab atop gemcitabine cisplatin. The discussant here did a particularly fantastic job in pointing out the importance of subset analysis and the real signal that needs to be further explored that this actually may benefit Asian patients more than our patients in the West. But regardless, this is exciting, and hopefully we can find not just which patients this fits, but which biomarkers can best guide us in treatment selection. I think we're all waiting with bated breath for S1815 to see if triplet chemotherapy might also unseat the doublet. And of course, that's going to be the combination of gemcitabine, cisplatin, and nanoparticle-bound paclitaxel in that SWOG trial. And then finally, I'd be remiss not to bring up HIMALAYA. So HIMALAYA was looking at dual immunotherapy in the setting of first-line advanced hepatocellular carcinoma. And here again, there's an abbreviation within an abbreviation, which is STRIDE, which rather elegantly stands for single-dose tremelimumab and then regular interval durvalumab. And the primary endpoint here was, again, overall survival, and that was met. So the median OS in the IO arm was 16.4 months versus 13.8 months in the sorafenib control. And I know already some critics will say, well, that's not the appropriate control arm in the advent or the aftermath of IMbrave 150. However, in designing this trial, at the time it was designed, I think sorafenib was a reasonable control. I'll also point out, I think this dual IO approach is potentially giving us a therapeutic alternative for patients who would otherwise be excluded from the exposure to atezolizumab, bevacizumab on the basis of, say, varices, high risk for bleeding, or incompletion of upper endoscopy to aggressively exclude varices. So again, I think there's a widening here of candidacy for immunotherapy. And finally, and on a personal note, as I mentioned in a prior column, HIMALAYA was actually a trial where I had enrolled a patient who passed away, but had asked me to convey the results of the study, whatever they were, to his widow posthumously. And the fact that this was a positive study when it matured was actually of reassurance to that very, very gracious woman. And her late husband said that if he could help even one person by his contribution to this study, then his participation would have been worthwhile. And so I'd be remiss not to kind of end wistfully that I wish this combination could have helped him more, but I'm glad that it might help other HCC patients in the here and now and in the future. So as always, ASCO GI gave me renewed hope. I'm so grateful for all the researchers out there who are dedicating themselves to some very, very difficult to treat diseases indeed, but I think we can see both an immediate and a potential impact in our clinics. Mark Lewis from Medscape. Take care.